Hi, everybody. This is Dr. Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly. And you're watching and listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us, both professionally and sometimes personally. So it's my pleasure to talk to thought leaders and innovators and people from all over the globe who impact our specialty and our lives. And today my guest is Mick Connors, who actually is a pediatric emergency physician and started Anytime Pediatrics in 2016, and has been very, very successful in what they're doing, especially as it was impacted by the coronavirus and transitioned into a lot of telehealth. Welcome to the broadcast, Mick. I'm happy to have you. You're an ER doc first, a pediatrician, I guess, second, and an entrepreneur third. Is that right?
Yes, and maybe sometimes depending on the course of my career in different orders, but absolutely, yeah. So it's great to meet you, and thank you for the invitation.
Pleasure. Tell me a little bit about yourself. I mean, sometimes it's really important for us to know who we're talking to. Where are you from? Where'd you go to school? And what led you to this? Tell your story.
Yeah. It's I'll give you the short version of my long story, but I'm the seventh of 8 kids, so I think that's why pediatrician was always part of my life. I've always been around no matter what, so I think away from it. But so that really kind of inspired me to be a pediatrician. My oldest brother, passed away before I was born of Wilms tumor, and that inspired me to be a physician. Wow. Always thought I'd be a pediatric oncologist, but having done some med school rotations in oncology, I decided I was a little too close to home, and I said, gosh, this new field of pediatric emergency medicine looks pretty attractive. I actually, in med school, met the first pediatric emergency medicine fellow, is a gentleman named Mike Altieri, when I was working in Richmond, and he came out of Northern Virginia. I had no idea what pediatric emergency medicine was and never heard of it. And the other ironic thing, I guess, as our careers go, is I being 7 of 8 kids, I never had chickenpox as a kid. My titers were negative when I was a pediatrician. So as a resident, every time I got exposed in the hospital, it was before the varicella vaccine, they put me in the ER. I spent a lot of my training in the emergency department, and for whatever reason, I think I kind of fell in love with pediatric emergency medicine and child advocacy. And as you know, it's such a unique specialty, and there's so many different variations to what we do and how we do it. It just was attractive from the get-go.
So, your residency was where, and kind of give me a thumbnail of your practice career before you formed Anytime Pediatrics.
Yes, I did most of my training at Cincinnati Children's. I was a pediatric resident first. And then matched. I was the fortunate group that had to do a 3-year pediatric emergency medicine fellowship. We were the first ones, so went from 2 to 3. And ironically, my wife got transferred to White Plains and IBM. So I actually did my first year of fellowship in the Bronx at Jacoby Medical Center.
I've been there. I did some work there.
Yeah, which was a whole nother experience. We can talk today.
We could talk a long time about Jacoby.
And then I went back, and my wife stayed home with our 2 kids, and we went back to Cincinnati, and I finished up my training there. From there, I went to East Tennessee Children's in Knoxville, Tennessee, which is a small pediatric children's hospital, because I really wanted to practice emergency medicine. I really wasn't attracted to, academics or research or things like that. I wanted to be a doc and be hands-on, and that hospital gave that opportunity. So we were there for a long time. I did pediatric emergency medicine. My first entrepreneurial endeavor was actually pediatric sedation. In 2004, we started a sedation service to help kids get care outside of the operating room, which was a whole nother endeavor. And then from there, went to Connecticut Children's. Wanted to get out of the business side of medicine and go back into kind of academics and help them build their sedation service, learn pain medicine. And that was just too cold up there for us. And so we came back to Tennessee, and I actually started working at Centennial Hospital in Nashville and went back in the emergency department. And it was I hadn't done an ER shift for about 8 years, but it was great to be back. And it was we all go through our periods of stress and burnout and things like that, so I felt like I had a fresh perspective and came back into pediatric emergency medicine. And there's just unique things about it that you always kind of enjoy and do clinically and see.
Yeah, pediatric emergency medicine is that that blend of you want to see sick kids, and you don't want to see just runny nose after runny nose after runny nose. That unfortunately is kind of the stock and trade of the office pediatrician. They have a few sick people, but oftentimes they refer them out. And pediatric emergency medicine is really where the rubber meets the road with kids, diagnosing really sick kids and managing kids, and especially pediatric trauma. I think some of the most difficult things I've ever done in my entire life is dealing both parents and children who have undergone high acuity pediatric trauma.
Yeah, no, I think it's an interesting field. It's I often think about it as kind of looking for the needle in the haystack, right?
Yeah, exactly.
Runny nose, one out of those 100 runny noses is going to be something else. And can you get yourself away from just thinking about one differential, right? So that in pediatrics, I think, is our ultimate challenge, trying to identify that sick patient, that kiddo who doesn't quite match up with the algorithm or doesn't look like everybody else. And a lot of times it's kind of gut and experience and those kind of, but it has its unique challenges with parents and patients and nonverbal and all those kind of things. So it's always was always the fun of the diagnosis, right? Trying to interpret all the information that you're getting.
I remember in medical school, a professor who told the class that his sister had a runny nose for literally several years, and the mother and father had just kind of gotten used to it and didn't really think anything of it until they finally took her to the ER for something else, and some enterprising emergency physician looked in her nose and found a straight pin that had been put in her nose as a kid, when she wasn't falling on. They didn't even know how it got there, but it had been there for several years, obviously causing irritation and rhinorrhea and whatnot. And so you do again get those pediatric ER stories of fascinomas that you don't expect. Well, tell me first off, I want to switch gears a little bit and talk a little bit about your company, Anytime Pediatrics, and we'll talk a few minutes here about. We're going to talk a little bit about the things you've done with telemedicine in Anytime Pediatrics in response to the pandemic. So let's start, and tell me what gave the idea of the Anytime Pediatrics. It looks like you're working with your wife. Is that right?
Yep. Always align yourself with smarter people than yourself, right?
That's right. And every successful man is a woman with a gun, right? Or a brain. We're not sure which it is.
Yeah, I'm blessed. She's a very smart person. She ran the sedation service kind of on the practice side. When we moved to Connecticut, she ran 4 divisions up there. So she kind of brings the practice manager standpoint to our business. But it all comes back to, I guess, part of my career. I've been while being in the emergency department or being in sedation, has always been interested in clinical integration and population health and how to get. As you know, it's not about, it's really much more about workflows. Like, how do we get the patient to the right place at the right time with the right provider, right? So in emergency medicine, we see plenty of kids, we see plenty of adults that go to the wrong place with the wrong provider at the wrong time. And it really, to me, has always been, kind of like the sedation service, which was our first innovation, which was really about every patient's different and every patient needs something different for that procedure. So how do you get the patient to the right place at the right time with the right provider, with the right medication, so you give the patient what they need. And so, I went back to the ER, as I mentioned, at Centennial, and, the most remarkable thing was just seeing how many, the transition of, I don't know how your career has been, but I certainly, my first 10 years in the emergency department, we were talking to pediatricians, we're referring patients back and forth, we're talking about their patients, we're calling them at midnight, updating them, they're calling us to say patients are coming in. I leave, I come back 8 years later and everybody's been to a retail clinic or an urgent care or, has gotten a prescription from a random doc online. And, I'm not talking to pediatricians anymore. They're might leave a message or they just send the kid on, right? I don't call them back. I mean, it's discouraged. Like, why are you calling me? So there's this big giant disconnect that's really evolved. And, Mark, probably the thing that's impacted me most around telemedicine was I'll never forget it because, ironically, in those 8 years, we also went from paper predominantly to electronic health records. And so I was able to see this patient who was 2, who had no chronic conditions, and had been in the ER 27 times.
Oh my gosh.
So we're all like,
moly.
holy moly, right? Like, this mom doesn't get it. She's just using the ER inappropriately. And, I was fortunate enough because I'd kind of lost some of that cynicism in my years away. So I said, I could walk in, I could take care of this, right? I could say, hey, Mom, how you doing? Looks like your son's been here a lot. Looks like he's doing pretty well. Can I help you get connected with a pediatrician? And I'll never forget this young lady, because she looked me right in the eye and said, Doc, you don't get it. She's like, I work Monday through Friday, 9 to 5. I work a minimum wage job. If I leave work, I don't get paid. If I leave work, I might get fired. And I go to a community health center, and they're available Monday through Friday, 9 to 5. And I was like, wow, like, okay, I need to sit down and listen to you. And okay, now why are we here today? Right? Totally.
That's right. What she just summed up right there is why emergency medicine has continued to grow throughout my entire career. Throughout my, and I did a history of what actually drove emergency medicine. It was not, we eventually developed a body of knowledge that was unique to us, but that's not how we started. We started by being available. It was a delivery model that we delivered hopefully the same or better care, but what we actually did, we delivered care when people needed it. And that's what blossomed emergency medicine. That's what you're talking about with pediatricians and pediatrics and taking care of the kids. If you're available, they're going to come.
Yeah, you build it, they will come. And so for me, it was like, gosh, and just especially seeing, even when I started at East Tennessee Children's Hospital, our volumes were pretty light. It was a pretty small place, but man, by the time I, left the emergency department, 6-7 years later, we're multi-staffed. Patients are coming through the, rafter, right? Things were just crazy. In a little small town, we were, seeing like 60,000 patients a year in a free children's hospital pediatric emergency department. And when I over the last few years, I've done locums, and just been really interesting to see the different perspectives from the different ERs. But I do some work at Dayton Children's Hospital, a phenomenal facility. But it's amazing how many nurse practitioners we have, and how many folks are, we have suture folks and nurse practitioners and pediatricians, and just overwhelming volumes pre-pandemic, right? Where you're just trying to take care of these folks. And on the patient side, you're hearing a lot of, I don't have access. I called my office and I can't get in, or there's a phone tree, or they tell me I can't. Or you talk to the pediatricians, they're like, hey, we're here. I don't understand why they're not coming in. And, there's been a lot of push for convenience and, rapid fire, drive-through medicine, all those kind of things. So I just recently called, I forget who it was I was calling. I think it was the medical society, but or maybe it was one of the providers. I'm not sure. I don't recall. But it was so frustrating. They had a 9-part recording tree that you had to get through before you could actually, you're after a while you're screaming, agent, doctor, agent, give me a body. I want to talk to somebody, and it's so mechanized. You're talking to a bot, you're talking to and there's place for that. I understand, but and I support those. Don't misunderstand. I'm all for telemedicine, but it can create an office, can tell you this, if you have a medical emergency, hang up and dial 911. Everybody, we got that. Yeah. It's all that way, right? Between the runny nose and the 911 call, that's what we're trying to figure out, right? That's what we're calling.
Okay, so tell me then, given all that, how did you develop Anytime Pediatrics?
Yeah, so it was really interesting because I come at it, I'm a clinician, I'm a pediatric emergency physician, pediatrician, right? And I really came at it from the workflows. So I'm not a technologist. I'm not like sitting around, checking out the latest gizmo and gadget and things like that, wondering how I can, put this gadget into practice. I actually thought about telemedicine, much like, like what we're talking about here. Like, how do you get the patient to the right place at the right time? And how can we use technology to do that? Because in 2016, when I was looking at it, one, I was working 12-hour shifts, so I had some free time, right? So I'm like, gosh, what am I going to do? Because I'm an ER doc, right? We don't sit still. We're not working our shift, playing golf, unfortunately, as much.
Yeah.
We're all in it because we're got ADD and we're trying to figure out the next, iteration of whatever. So, I started looking at telemedicine, really thought about being a telemedicine doc, and hey, I could check this out. And then I started to look at the technology, and I'm like, wow, this is really cool. Like, everybody's got a smartphone now. It's amazing what you can see, all those things. And I started looking at companies, and everybody was what I call the Uber model, right? It was, hit a button, see the doc, right? It's just kind of like getting a car ride for somewhere, right? I mean, delivering care is no, right? You just hit a button, and whoever you see is who you're going to get. And I just didn't understand that, right? To me, it was much more about, I want to go to an ER where someone is trained to take care of me in emergency medicine, or I want to go to a physician that's trained in pediatrics. I hope you have a license to drive me across town, and I think I'll get there whether we go the wrong way or not. But when it comes to healthcare, it just seems like parents, especially being a pediatrician, or in the old days, it was you call your pediatrician and you wait for them to call back, right? And to your point around technology and around advancements over the last 10 years, now you have a retail clinic, you have a nurse line, you have urgent care, you have a pediatric care, you have a children's hospital, you have a general hospital. Where does a parent go when they're somewhere between that runny nose and that 911 call? And they're very confused, what I see, right? They don't really know. So to me, it was like, wait a minute, how come we can't get kids reconnected to a general, source of care like primary care? If primary care is not available, how can we, use technology to guide them to that pediatric urgent care, or pediatric emergency department, and kind of use that continuum of care and just use technology to replicate it, right? As opposed to disrupt it or fragment it, or, kind of wind up into just, one care after the other, right? So, I mean, we all see that, right? We see kids that come in the ER because they've been to the retail clinic and the urgent care, and their parents will look at you and say, I have no idea why he's on these antibiotics, right?
Right.
I can really tell they had no idea what they were doing, so they threw me on steroids and antibiotics, and I came here because I want to make sure everything's okay, right? So
there's so many follow-up visits I see in the ER. They come in, they hand me the record. So when did you did this in 2016? And what was did it start as an actual physical clinic, or tell me about Anytime Pediatrics? Is it just digital?
Yeah, so it's we started down the path of what is telemedicine. I started the company, looked at the technology, hired a technology company to help me kind of, hey, what is telemedicine? Here's the kind of the workflows I'm thinking about. Can we go find a company that has that and we can just use it, right? Well, of course they didn't exist. They were all kind of looking at it from that other model. And so I actually got 4 of my fellow pediatric ER friends to say, hey, let's try a pilot with telemedicine and see what this is. Like, is this going to work, right? I mean, so we were able to get a pilot. We had a group out of Memphis, and we attached it to a nurse call line, and so the family could choose to say, hey, I don't want to go to the urgent care. I'd like to try Anytime Pediatrics. And so we did that for about 2-3 months, and it was it took us all about 2 calls to realize, man, this is pretty cool, right? Like, the families decided all they really wanted was reassurance and advice. And we have a long history of research on telephone triage in pediatrics, of how successful it is when a child's connected to their pediatrician or a pediatrician that can save some of these ER visits and give people access and give them the reassurance they want. As 80% of what parents really want and need is reassurance, typically, about their worries about their child. So
and information. But my question is a real practical question: is how'd you get paid for it?
Yeah, so pre-pandemic, we charged, the parents would be charged like a $60 fee.
Okay, so it was a fee-for-service model.
Yeah, so it's kind of a convenient service, and we did that for a while, but we certainly recognized pretty quickly that staffing and hiring and doing all those kind of things wasn't really where I wanted to go with it, both from a business perspective, but also a clinical perspective. Because as there's a physician shortage, there's a lack of, as you see the random folks recruiting and retaining and trying to hold on and get more docs to do things, in a physician shortage, I was always like, gosh, if we could use technology to mobilize the current workforce, right? And to use technology and use telemedicine and it be more efficient, that would make a heck of a lot more sense, right? So if we could get, there's a pediatrician on call for every practice in every city and every town, and right, and if they would take these visits, then we wouldn't need a whole nother layer of telemedicine virtualists or a whole new field. It was really, how do we get them to mobilize it? So how do we make the technology easy? How do we get the patients to use it? Patients wanted it, the more we researched, and it was the physicians and clinicians that were the holdup, right? We were like, I don't know about this. This is bad medicine. We can't really practice medicine this way. It's, and how are we going to get paid for it and all those kind of things. So,
And so your model, if I could interrupt you, your model is to organize pediatricians around your technology so that you are providing anytime pediatric care using the existing pediatricians. Is that correct?
Yeah, the pediatricians, the pediatric urgent care, the children's hospitals, the folks that you already have relationships with, that you already want to stay connected, you want to keep them in that network. That's my belief around the history of telemedicine. Telemedicine's not a new field it's a way to deliver care, but it's, as you and I both know, it's not about the technology, it's about who you connect with, right? It's the knowledge and experience of the person you connect with. So I don't know about you, but I give plenty of telephone advice to emergency physicians, right? Without seeing anything, without like wondering what that kid looks like. like, can you describe this to me? How are they breathing? What do they look like? Right. I mean, and it's a bit frightening, but gosh, a picture and a video by itself, if that's all you're going to use, it gives you a lot of information, right?
Well, as you know, when telemedicine all started out, the big hurdle that everybody had to get over was HIPAA, because the idea of transmitting this kind of information over an open line was just forbidden. And so everybody came out with these military grade, top secret, a kind of encrypted lines, and which were great, and they were very compliant. Also had an expense added to them, difficult, and sometimes getting people involved in them were difficult. And then suddenly we had the pandemic of 2020, and all that just kind of went out the window. It was, suddenly instead of having an encrypted line, all of a sudden FaceTime was just fine, And if the patient's okay, the doctor's okay with it, and everybody just FaceTimes, and we're just doing great. And in 1 year, we did a pivot from all these difficult platforms to one that we already had, and just said, do it.
Yeah, I mean, I think it's pretty remarkable. That's what I was seeing beforehand too, because a lot of the focus early on, as you know, in 2016, 2017 was fancy carts, fancy doodads and devices. And, we had one for our transport team in Nashville, and nobody knew how to use it because it had so many gadgets and Zooms. And, it's like, just pick up your smartphone and show me what the kid looks like, right? I mean, that's all I need. Give me a couple of vitals that you can take, and I don't need to automate, pan tilt zoom. I don't need to do an ultrasound en route. I don't need to do all these different things that you can do, and they're cool. But it's a $50,000, $100,000 device. When everybody's walking around with a video camera and a smartphone and can send picture. I mean, it's pretty remarkable when you think about really simplifying what virtual care could be and what it will be kind of going forward.
I will say though that as in my role here as a moderator and interviewer for EP Talk, I've come across some technologies that are really starting to push down into the public. I'll give an unsolicited shout out to things like butterfly ultrasound. For a handheld butterfly ultrasound is several $100s. I mean, it's within the range of anybody. And what we used to pay several $1,000s for a pulse ox, you can now buy in a grocery store or in a drugstore for $20. Yep. And so a lot of the technologies that used to be out of reach and used only in hospitals now are completely available to the public. If you want, you wouldn't have an ultrasound, but I'm saying, if you want to have a team go someplace, this idea of extending care out to the home using telemetry and such is certainly becoming more and more possible.
Right. Yeah. A couple of years ago, everything was in a big giant suitcase, right? And you had a
Yeah.
big set like this. I remember going to the ATA. It was like, you have all this stuff, and now, you can get an echo stethoscope. You can get a otoscope. You can get, you can do an EKG. You can do so many things, as you're saying, and talked with another pulse ox company the other day. It's just, Bluetooth right in, and it'll download vitals. There's so many different things that you can do that are great, as long as the technology is matching what you need, right? Sometimes we get a path where the technology is a hammer looking for a nail. And as we clinicians try to lead some of this, which was part of my passion, is this is really about the workflows and what we need to get the patient to the right care at the right time. It's not about, I got this cool gadget that now I want everybody to do an ultrasound on, right? Those kind of. So I think that's where physician leadership and entrepreneurship and innovation is really important.
That's
because sometimes, the way technology is going, it gets way ahead of us for sure. And we're slow adopters anyways, but sometimes it's just overwhelming. Like, I don't really need that. It's cool to have, but I don't want all that. Right. I just want to take a picture of the kid. I always want to see the rash, those kind of things.
Right. Well, I promised to keep this to 30 minutes for you. I know you're a busy guy, and you've given me a real insight. I want to alert all of our listeners and readers to anytimepediatrics.com, and you'll get an idea of what they're doing. If it kind of appeals to you, I think that this is something that Dr. Connors would be happy to talk to others about, and spread the knowledge of how to put these networks together and use existing tools, existing personnel. And you may be a pediatric emergency physician who would want to get involved in something like this. So I just want to, Mick, I want to thank you for joining me today. I think we just barely scratched the surface. You told a very fascinating story of your own life and how you got into this, but I think there's a whole lot more to talk about Anytime Pediatrics. So we'll do that probably another time. But I want to thank all of our listeners and our readers for joining EP Talk, a place where emergency physicians come to talk about things that are important to us and impact our personal lives and our professional lives. So thank you for joining us, and goodbye.